about the gut microbiome in disorders of the gut-brain interaction. So please, Dr. Clark, very welcome, and we are very kind to hear you.
Thanks very much, Enrique. It's a real pleasure to join you to talk about the gut microbiome and disorders of gut-brain axis interaction, and I really appreciate the invitation to do so. So as Enrique said, I'm based in the Department of Psychiatry and Neurobehavioral Science, but also APC Microbiome Ireland and University College Cork. And APC Microbiome Ireland is a Science Foundation Ireland funded research centre dedicated to the study of host microbe interactions. These are my disclosures. So in this book by the Irish author Kevin Barry, the characters, because of the melancholy and the haunt of melancholy associated with living in Ireland, they need to go to the mental health asylum for treatment, which is colloquially referred to as the bug house. So over the next 20 or 25 minutes or so, what I hope to convince you was that rather than going to a physical bug house, that we can look to the bug house within to remedy our gut and mental health issues. So we've been working in this area now for maybe 15 years or more. And what we've been trying to do is figure out the scope of influence that our gut microbes have on brain function and behavior, try to understand the mechanisms underpinning those observations. We've been looking to this across the lifespan, really, and then trying to see in a translational approach if we can move what we've been observing in our animal studies from bench to bedside. Now, all of this is possible really by the framework provided by the brain-gut axis, and this describes a bidirectional network of communication between the gut and the brain, and it's increasingly recognized that the microbiota is an important node within this axis. So here you can see the main components of the gut-brain axis. For example, the vagus nerve is a direct neural channel of communication between the gut and the brain, with the gut being heavily innervated by the vagus nerve. There are also a number of other key pillars of the gut-brain axis, like the immune system or the core stress response system, the hypothalamic pituitary adrenal axis or HPA axis. And also within this, we have our microbes then, and they're like mini factories really, churning out microbial metabolites from the raw materials we provide them in our diet, like short-chain fatty acids or tryptophan metabolites to influence gut-brain axis signaling. So what we view this then as the microbiota being able to hijack these different signaling pathways between the gut and the brain to influence things at the level of the central nervous system. And then, of course, this is a two-way street because we know as well that stress perceived at the level of the central nervous system can also alter the composition and function of our gut microbiota. So because of the many functions then that this gut-brain axis fulfills, the microbiota has a broad scope or a broad potential to influence both gastrointestinal function in terms of basic aspects like gastrointestinal motility, secretion, or permeability, while also having a route to control more complex functions that have a central nervous system component in relation to visceral pain, hunger, mood and emotion, or cognition. I'm going to focus mostly on irritable bowel syndrome as a prototypical disorder of gut-brain interaction. And we see this with its gastrointestinal symptoms, including abdominal pain, constipation, and diarrhea, but the abdominal pain thought to be underpinned by visceral hypersensitivity, and there are a network of brain regions like the anterior cingulate cortex which may regulate this. There's also a very high psychiatric comorbidity with high prevalence of anxiety and depression, for example, in irritable bowel syndrome. Stress plays an important component here because we know that stress can markedly alter signaling along the gut-brain axis, and this can be reflected or visualized also as a footprint at the level of the gastrointestinal system and within the microbiota itself, with one example being early life stress, which is a very important risk factor along with adverse childhood experiences for the subsequent emergence of irritable bowel syndrome in adulthood. And really what we've been trying to do is figure out this puzzle as to where the microbiome fits here and how, if we use it, can we chart a way forward that allows us to identify companion biomarkers and maybe more precision or personalized treatment options for the various presentations of irritable bowel syndrome, given the heterogeneous nature of the disorder. Now, in order from a preclinical basic science perspective to try and figure out what aspects of brain function and behavior are influenced by the gut microbiota, we use a number of different experimental approaches. Some of these are pretty intuitive in terms of administering antibiotics or prebiotics or probiotics, and some need a little bit more elaboration in terms of the use of germ-free animals, where we can figure out whether a certain aspect, get a yes/no answer, but whether a certain aspect of brain function and behavior is under the control of the microbiota. And this is a pretty neat approach because it tells us, as I said, it gives us a yes/no answer about a particular aspect, but it also allows us to manipulate the germ-free animal later on by reintroduction of a more complex microbiota to see if the aberrant phenotypes that we've noted can be rescued. So collectively, these different approaches have told us from a central nervous system perspective that the microbiota influence behaviors relevant to anxiety, depression, pain, and cognition. Some of the key observations coming from germ-free animals are illustrated in this slide here. For example, we know that germ-free animals, when you stress them out, they have an exaggerated stress response, and that can be picked up by monitoring the levels of the hormone corticosterone, which is an index of HPA axis activation in animals. And this tallies pretty well what we know from other approaches where probiotic administration has been shown to reduce the stress-induced production of corticosterone. From a behavioral perspective, we see that these germ-free animals have altered anxiety-like behaviors, again, something that can be rescued by colonization of the animals post-weaning, and tallying pretty well with what we know about various interventions like specific bacterial strains, which have been shown to reduce anxiety-like behaviors in classical screens that would have traditionally been used in the pharmaceutical industry to identify anxiolytics or antidepressants. The microbiota has an important role also in regulating visceral pain. So we can see here that in germ-free animals, there's an altered pain threshold, which again can be normalized by colonization of the animals post-weaning. And if you look to the central nervous system and these key network of brain regions that are associated with the regulation of visceral hypersensitivity, we can see volumetric changes, for example, in germ-free animals in the anterior cingulate cortex, as I said, a key region for that visceral hypersensitivity phenotype. Now, overall, if you look to the germ-free phenotype, you can see that they are markedly altered as a consequence of growing up across the lifespan without their microbes. So if you miss your microbes across your lifespan, you're going to have markedly altered behavior. You'll demonstrate or visualize immaturity at the level of the enteric nervous system, as well as central nervous system dysfunction and immaturity across a number of key brain regions. We've mentioned, for example, the anterior cingulate cortex, but there are also alterations in key brain regions that are very important in the context of psychiatric disorders like the amygdala for fear and anxiety, or the hippocampus for memory and learning, or areas of the prefrontal cortex for the integration and expression of emotional experiences. And what we see in our germ-free animals is often backed up by other approaches that I've talked about, other experimental approaches like administration of probiotics or prebiotics, converging on the alteration of these different behaviors and aspects of enteric and central nervous system function and maturity. Now, in terms of translational research, we often use these sequencing approaches where we can look in stool samples for microbial DNA and essentially conduct a census to find out maybe who's there and maybe more importantly, who's missing. And we know now that there are alterations in a variety of different psychiatric disorders, including depression and anxiety, as well as in irritable bowel syndrome in terms of either the composition or the function of our gut microbiota. Now, a number of different studies have been conducted to illustrate this point in the context of irritable bowel syndrome. And this is a recent paper from my colleagues here back in APC Microbiome Ireland, where they collectively analysed or reanalyzed the data that was available from studies looking at the microbiota in irritable bowel syndrome. So, for example, they took these data sets that were available and pushed them through a uniform 16S or shotgun metagenomic sequencing data processing pipeline to try and see whether there were common signals coming through. Because although there are many studies looking at the microbiota in IBS, and all tend to show some modifications, it's been difficult to find a common signature amongst those different studies, although there are evidence coming through now that there are indeed those common features altered. And what this study illustrated, for example, was that there are about 60 statistically significant differentially abundant species, which are either enriched or depleted in irritable bowel syndrome compared to healthy controls. And they showed as well that the taxa, which are commonly depleted across studies, or commonly depleted in at least a number of studies, are primarily short-chain fatty acid producers, and that also 2/3 of the species which are enriched in irritable bowel subjects could be classified as pathobionts. So those studies are often cross-sectional in nature, and they shine a spotlight at a specific point in time to show that there are differences in the microbiota composition or function between individuals with irritable bowel syndrome and healthy controls. But they don't tell us about whether those differential compositional features of the microbiota could have a causal role in symptom generation. So often, to try and answer that question and to try and get at the causality angle, fecal microbiota transplantation experiments are performed to see whether a disease-associated microbiota might induce symptoms relevant to the disorder in question. So this is a review we published on this topic, and there's also some guidelines around transparent reporting. And this has been deployed in a number of studies looking at irritable bowel syndrome. So what I'm showing you here, for example, is a study from Primul Berchik and colleagues in McMaster University, where they harvested the microbiota from IBS subjects with or without comorbid anxiety. And one of the key findings here was that only the donor microbiota from subjects which had comorbid anxiety, when transferred into animals, where the recipient animals displayed both anxiety-like behaviors and alterations in gastrointestinal function. So a very specific transfer of comorbid psychiatric phenotypes. Subsequently, the same authors went on to repeat that observation, and this time they were able to show that the gut microbiota, or the irritable bowel syndrome associated gut microbiota, when treated or targeted with a Saccharomyces boulardii strain, was able to ameliorate both aspects of the gastrointestinal and the central nervous system dysfunction induced by the IBS-associated microbiota, indicating that this IBS-associated microbiota can be a therapeutic target to reduce symptoms in irritable bowel syndrome. We've also been able to show this in the context of the psychiatric comorbidities that are commonly expressed in irritable bowel syndrome. So here we've taken the depression-associated microbiota and transferred it into our animal models, and the recipient of that donor depression-associated microbiota displayed anhedonia-like behaviors, which is a very common feature of depression. They also showed alterations in anxiety-like behaviors, which is very frequently comorbidly expressed in depression, as well as alterations in metabolic pathways of relevance to the neurobiology associated with both IBS and depression in terms of alterations in tryptophan metabolism, which I'll come back to a little bit later. We've also shown this recently in the context of other common psychiatric comorbidities like anxiety in irritable bowel syndrome. So we've shown that there are alterations in the microbiota composition and function in social anxiety disorder, for example, and that can be transferred via the depression from donor humans to recipient animals. Now, at the minute, we're working with collaborators across Europe in the Discovery Consortium, including my co-speaker today, Magnus Simran, to try and figure out what's going on in the complex presentations that come with irritable bowel syndrome in terms of psychiatric comorbidities, and why do specific microbiota configurations on one hand sometimes generate a purer form of irritable bowel syndrome, but just gastrointestinal dysfunction, while on the other hand sometimes lead to the manifestation of more complex heterogeneous phenotypes relating to gastrointestinal and psychiatric comorbidities like anxiety and depression. So we're trying to essentially, in Cork here, we're the preclinical site, trying to figure out the signaling pathways involved in that. Now, there are a number of mechanisms, as I mentioned at the start, through which the microbiota might be able to modify signaling along the gut-brain axis. And one very important component is tryptophan. Tryptophan is an essential amino acid. It has to be supplied in the diet. Once it's available in the diet, then it can be a precursor to a variety of neuroactives within the gut-brain axis. Probably the best known outcome for tryptophan is the conversion into serotonin. You may know serotonin as a therapeutic target for many commonly and successfully deployed antidepressants and anxiolytics in the clinic. So serotonin has an important role in the control of multiple aspects of behavior, but also, of course, serotonin, the largest pool, resides in the gastrointestinal tract, where it regulates fundamental aspects of gastrointestinal physiology in relation to motility and secretion. We know as well that our microbes can process tryptophan, so it's not just host pathways for tryptophan metabolism, but also microbial processing of tryptophan into things like indole and tryptamine. And this is a very important study from, or a description of a very important study from M.A.S.P and colleagues, showing that bacterially produced tryptophan, bacterially processed tryptophan into tryptamine was able to interact with host serotonergic receptors in the gastrointestinal tract to modify gastrointestinal motility. There are other important signaling molecules that our microbes produce, like short-chain fatty acids, for example, which can also be heavily implicated in gut-brain axis signaling and modify relevant features associated with irritable bowel syndrome, like visceral pain. The barriers, both in the gut and the brain, share many similarities and are also seen as important conduits through which our microbiota might be able to influence aspects of gastrointestinal function and also aspects relevant to brain function. And this has been demonstrated very elegantly recently by Giovanni Barbara and colleagues, where they were able to implement the workflow shown on this slide here, showing that mediators from IBS subjects released into preparations was able to modify gastrointestinal permeability, both at the vascular and epithelial layers. So the perspective that comes from this then, in which my co-speaker, Professor Simran, is going to take up, is that the gut microbiota plays an important role in determining both core IBS symptoms and also psychiatric comorbidities, and that then it can be mined for new therapeutic agents and also targeted with various options like probiotics, prebiotics, or diet to try and induce symptomatic improvement. Now, we've been looking at this just in a healthy control study here to see whether we can switch people from their standard Western diet, for example, to a Mediterranean type diet characterized by increased fiber and fermented food intake. And this initial pilot study that we've conducted has shown that indeed we're able to modify the perceived stress of participants in this study, as well as altering microbial tryptophan metabolism. So this is an approach that we're very keen on progressing and seeing how it can be implemented now in different pathological states, including maybe depression and the psychiatric comorbidity that is evident in irritable bowel syndrome. In terms of the future of this field and where we go to try and maybe move to more personalized options, there are a number of different groups now that have tried to implement these clustering approaches, I suppose, to identify different categories of individuals with irritable bowel syndrome. And the idea, I guess, is that we can try and identify these particular clusters and then maybe target them with more precision with specific treatments for each particular cluster in terms of whether they exhibit bowel or other psychological dysfunction in combination with their irritable bowel syndrome core features. My co-speaker as well has also developed pipelines that might be able to identify how the GI symptom layer and the psychological symptom layer interacts at the level of the mucosa to try and identify specific clusters that might be targeted, as well as neurobiological or pathophysiological features that might be driving the many different aspects of IBS. So to summarize and conclude, I think there's a lot of support now, both from preclinical and clinical research, to indicate that the microbiota has a key role in driving multiple aspects of the symptoms associated with irritable bowel syndrome. we've moved on from correlation to focus on causation and identify potential mechanisms underpinning these observations, with barrier function and microbial metabolites in particular being key. We're looking much more to translate these observations now from bench to bedside and seeing whether we can feed the bug house with N for more precision treatment of disorders of gut-brain axis interaction. So I'd just like to finish up with some acknowledgements for the gut-brain axis research team here back in APC Microbiome Ireland. A few quick plugs before I finish. In addition to thanking you for your attention, there's currently a special issue of BMC Gastroenterology and Disorders of Gut-Brain Axis Interaction. If you have any interesting observations you'd like to send our way. And just a call out as well for the Neurogastro 2025 meeting, which will be held in London in September next year. We'd love if you could join us there to discuss more about disorders of gut-brain interaction. So thanks very much for your attention. It was a pleasure joining you.
Thank you very much, Gerard, for this wonderful overview. We will do questions at the very end and collect all questions. Please, all participants to the webinar, you can also post your questions in the chat function, and we will gladly relay those on. So it's now my pleasure to introduce the next speaker, who's Professor Magnus Simran. Magnus is the professor of medicine at the University of Gothenburg and also a visiting professor at the University of North Carolina, Chapel Hill. He's extremely experienced in dealing with IBS and has a big research interest in the gut microbiome and nutrition. And he's also a great speaker, so I really look forward to his talk, which is titled How to Manipulate the Gut Microbiota in Clinical Practice. So please, Magnus.
So thank you very much, Daniel, and thank you to the European and the Mexican associations for inviting me to give this presentation on how to manipulate the gut microbiota in clinical practice. And my talk will follow up on what Gerard has presented on gut microbiota alterations in IBS. So this is my first slide, just demonstrating how we define the disorders of gut-brain interaction today. This is a group of disorders where IBS is one of the disorders, and these were formerly known as functional gastrointestinal disorders. They are defined based on symptoms, but the symptoms can be related then to any combination of different pathophysiological alterations, such as motility disturbance, visual hypersensitivity, altered mucosal and immune function, altered gut microbiota, or altered CNS processing. And IBS is, as you know, one of the most common and well-known disorders of gut-brain interaction, and the focus of this talk is mainly on gut microbiota manipulation in irritable bowel syndrome. And IBS is defined as a combination of abdominal pain and different bowel habit abnormalities. So the abdominal pain should be related to defecation or associated with a change in the frequency or form of stool. And we can divide our patients with IBS into different subtypes depending on the predominant bowel habit, that is IBS with constipation, IBS with diarrhea, or IBS with mixed bowel habits. When it comes to the pathophysiology of IBS, we've heard that partly from Gerard already, that the pathophysiology of IBS is complex and to date incompletely understood, but we have a variety of different factors that are considered to be of importance in irritable bowel syndrome and the other functional bowel disorders. And among these, gut microbiota has received a more and more prominent role in the pathophysiological picture in IBS, which is where interactions between the gut and the brain are of great importance. And there are factors in the periphery that are important, but also, as we heard, factors in the central nervous system that play a role in symptom generation in these disorders. And there are indeed studies that have demonstrated alterations in the gut microbiota composition and function in patients with IBS, here exemplified by findings in a relatively recent systematic review of existing literature on studies associating the gut microbiota alterations with IBS, where there are indeed some bacteria that are reduced and others bacteria that are increased in patients with IBS. And if you think about the gut link with gut microbiota and symptoms in IBS and IBS in general, there are clinical scenarios that support this link that I'm sure that you're aware of. For instance, a proportion of our patients can have their symptom onset in relation to gastroenteritis, where symptoms continue after the gastroenteritis in roughly 10%, whereas 90% of subjects who have gastritis heal and do not continue with IBS-like symptoms. And there is also the scenario where you give a patient a systemic antibiotic. You may induce some kind of dysbiosis, which then leads to leads to symptoms compatible with IBS. And then the third scenario is what we're talking about during this presentation, namely how we can modulate the gut microbiota in order to treat symptoms of IBS or improve the symptoms. And this is what I will review for the remainder of my talk. So we try to focus on the gut microenvironment and how microbiota interacts with other factors in the gut and leads to symptoms, but also how gut microbiota can influence the gut barrier, the gut barrier integrity, and also the underlying immune system, the underlying nerves in the gut, and also the gut-brain axis interactions that are key for symptoms. So what we can try to do then is to try to modulate the gut microbiota interactions to actually improve symptoms in patients with IBS, to affect factors in the lumen, but also in the underlying mucosa in order to treat the symptoms. So we will review during this talk different ways of modulating the gut microbiota and how this has been shown to be effective for treating symptoms in IBS. We'll cover antibiotics, probiotics, prebiotics, food, fecal microbiota transplantation, and that's what we will focus on during this talk, each of them. And when you think about how these gut microbiota modulation therapies can actually influence symptoms in IBS, there are different ways through which this can happen. And this is a cartoon showing the principal modes of action for antibiotics, probiotics, and prebiotics, where you can have more general effects of these interventions influencing the gut microbiota composition, the gut microbial metabolism, and also effects on the gut barrier function. But there are also more strategy-specific modes of actions, such as for antibiotics, bactericidal effects and effects on microbial fermentation, for probiotics, growth of probiotic bacteria, and for prebiotics, growth of health-related bacteria, both of these eventually then leading to immunomodulation. We start with antibiotics. There are gut-specific antibiotics. The most well-known and well-studied specific antibiotic is rifaximin, which has been shown to have an effect on gut symptoms in patients with IBS. And the approval in the United States for use of rifaximin for non-constipated IBS was based on this publication from Mark Mentel in New England Journal of Medicine in 2011, where they gave rifaximin for 2 weeks and then versus placebo, and then followed the patients over to a period of 3 months. As you can see, the patients in the rifaximin group were more likely to have adequate relief compared to the placebo group, which was statistically significant, even though the relative superiority over placebo is relatively modest. We will now move on to the other biotics, and to set the scene, I would like to give you some definitions that has been provided by the International Scientific Association for Probiotics and Prebiotics. So a probiotic probiotics are live microorganisms which, when administered in adequate amounts, confer a health benefit on the host. Whereas a prebiotic is a substrate that is selectively utilized by host microorganisms, conferring a health benefit. The other biotics that we'll not specifically deal with during this presentation are symbiotic, which is a mixture comprising live microorganisms and substrate or substrates selectively utilized by host microorganisms that confers a health benefit on the host. A postbiotic is a preparation of inanimate microorganisms and or their components that confers a health benefit on the host. There are deliberately inactivated microbial cells with or without metabolized or cell components that contribute to demonstrated health benefits. And finally, fermented foods are foods made through desired microbial growth and enzymatic conversions of food components. And when you think about the potential modes of action of probiotics, there are different potential actions that can lead to symptom improvement by probiotics in patients with IBS. So the probiotics can protect against pathogens in the lumen, either through antimicrobial activities or competitive exclusion of pathogens. But as we alluded to already, the probiotics can also influence other factors in the gut mucosa, such as immune modulation. They can have neurohumoral effects and also improve the barrier function. And there are several lines of evidence suggesting that gut probiotics can influence gut microbiota brain interactions specifically well demonstrated in animal studies, and that might be then relevant for symptom improvement in patients with IBS when using these probiotic drugs or probiotic products in clinical practice. There are several studies that have evaluated the efficacy of probiotics in irritable bowel syndrome. There are problems with many of these studies. Most of them are small, but when combined in systematic reviews and meta-analysis, they show some efficacy over placebo, even though the evidence supporting their relevance or their importance for symptom improvement in patients with IBS is relatively modest. And these are some summary statements from a recent, very well done systematic review and meta-analysis published last year in Gastroenterology, where the main conclusion from this systematic review and meta-analysis was that some combinations of probiotics or strains may be beneficial in IBS. However, certainty in the evidence for efficacy by grade criteria was low to very low across almost all of our analyses. So when they looked at global symptoms, they found moderate certainty in the evidence for a benefit of Escherichia strains, a low certainty for Lactobacillus strains and Lactobacillus plantarum 299V, and a very low certainty for combination products Lac Clean Gold S, Duolac 7S, and Bacillus strains. When it comes specifically to abdominal pain, they found evidence for a benefit of some probiotic products with a low certainty in the evidence for a benefit of Saccharomyces cerevisiae I3856 and Bifidobacterium strains, and a very low certainty for combination probiotics, Lactobacillus, Saccharomyces, and Bacillus strains. And moving on then to abdominal bloating and distension, they found a very low certainty in evidence for a benefit of combination probiotics and Bacillus strains. They identified a paucity of trials of probiotics in IBS with constipation. They found evidence for an effect of combination probiotics and Lactobacillus strains for global symptoms in IBS with diarrhea. But what is important is that they found the relative risk of experience and adverse events not significantly higher with probiotics than placebo. And this is of importance when we recommend it in this treatment in clinical practice, even though the evidence supporting the clinical benefit in clinical trials, what is important when we use these products in clinical practice is that they are very safe. And this is probably one of the explanations why most guidelines presented, and I've summarized them here in this relatively messy slide, recommend the use of probiotics in patients with IBS. We have here statements from the British Society of Gastroenterology, Canada, United European Gastroenterology, Italy, Japan, Korea, India, general Asian consensus, and also from Mexico, supporting the use of probiotics in IBS, even though all of them express some uncertainty of how effective they really are. It's actually only the American College of Gastroenterology that actually suggests against the probiotics for the treatment of global IBS symptoms. A few words about prebiotics. We heard about the definition of these, and they can stimulate, these substrates can actually stimulate then what you can call beneficial bacteria in the gut. And this is an example from studies that I've been involved in using human oligosaccharides. And what we demonstrated here was that they indeed increased the beneficial bifidobacteria in the gut. And in an open label, large clinical trial in the US, there was an improvement in overall IBS symptoms measured by the IBS symptom severity scale, as well as a normalization of the bowel habit. And there are now randomized control trials using this product underway. There are also other studies that have demonstrated an effect of prebiotics. This is a study from the group of Fernando Aspiros, where they demonstrated that in a randomized control trial comparing prebiotics and a low FODMAP diet, that both of these treatment options actually improved gastrointestinal symptoms in patients with functional gastrointestinal disorders, but they influenced the gut microbiota in different ways. But still, these treatments led to improvement of GI symptoms, implicating that you actually can modulate the gut microbiota in different ways and still receive symptom improvement. One of the newer kids on the block is fecal microbial transplantation that has been tested for IBS, but with some controversial results, conflicting results, both positive and negative trials. But some of the more recent and larger trials using fecal microbial transplantation in patients with IBS have been quite promising. And especially this trial from a group in Norway produced quite impressive results, where they used two different doses of fecal microbial transplantation and compared it with placebo. And as you can see, a quite substantial effect, a positive effect of the fecal microbial transplantation compared to placebo at 2 weeks, but then even more pronouncedly so at 1 month and 3 months. And they also recently published a long-term follow-up study where they followed these patients over 3 years, and they still showed beneficial effect after 3 years, as you can see in the graphical abstracts on the right on this slide. So some promising results from this study from Norway, but also similarly very positive trials from this trial from Belgium, where it's a little bit of a smaller trial, but a very nicely performed trial, where they demonstrated the superiority of the the active treatment with fecal microbial transplantation versus placebo. And on the right side, you see the benefit of all the different endpoints that were tested in this trial. So some promising results for fecal microbial transplantation, but we need to be careful. The jury is still out, really telling us which patient we should use these treatment for, and also how we should use it, we should be repeated, etc. So more trials are needed, even though these trials show some promising results. Finally, some words about food. As you all know, food is very central for patients with IBS, and is considered to be able to lead to symptom generation in many patients with IBS, and most patients with IBS actually report some adverse effects of different food items, and that food can actually exacerbate their symptoms. And this can happen through different effects in the GI tract, either through primary effects such as osmotic, chemical, mechanical, and so forth effects in the GI tract, or through secondary effects through diet microbiota interactions leading to fermentation byproducts, changes in interluminal pH, and effects on the microbiome. And through these primary and secondary effects, food can influence the different pathophysiological factors such as hypersensitivity, motility, etc., in order to lead to symptoms. So changing the diet is one way of improving symptoms in IBS. And the most widely studied diet is a diet where we reduce the so-called FODMAPs, which stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And these are poorly absorbed carbohydrates that can pass through the small intestine unabsorbed, reach the colon, where these carbohydrates can interact with the gut microbiota, which leads to fermentation, gas production, but also these carbohydrates can drag water into the lumen, and these effects then can lead to distension and symptoms in susceptible individuals. And there are indeed studies that have demonstrated an effect of reducing the FODMAP content in the in the food in order to improve symptoms in patients with IBS compared to, in this case, a typical Australian diet. And there are now several studies that have demonstrated a positive effect of a low FODMAP diet. This is a systematic review and network meta-analysis demonstrated that a low FODMAP diet was superior to other tested dietary advices for patients with IBS. And the effect is predominantly seen in IBS with diarrhea, even though there are some more recent studies, clinical follow-up studies, that have demonstrated an effect also in the other subtypes of IBS with this low FODMAP diet. There are indications, it's demonstrated that the gut microbiota is of importance when you assess the effect of a low FODMAP diet, and can also determine the response to a low FODMAP diet. This is a very nice study that was published recently in Gut, where they start by analyzing the gut microbiota in patients with IBS, and they demonstrated, as you can see on the left here, one group of patients shown in red here, which had a gut microbiota that was distinct from the healthy controls and from the also from the more healthy-like IBS patients when it comes to IBS gut microbiota composition. They saw then a response to a low FODMAP diet in both groups, as you can see on the middle graph, but you can also appreciate that the response seemed to be a little bit more even more favorable in the patients IBS-P, those with the more pathological gut microbiota composition. And indeed, when they assessed the gut microbiota after compared to before the low FODMAP diet, you can see on the left side here that in red, you can see that the gut microbiota in the patients with the pathological gut microbiota composition moved towards the group with the more healthy-like gut microbiota composition after a low FODMAP diet. And this could be demonstrated by several different analyses, both when it comes to microbiota composition, but also metabolic function, where the patients with the pathological gut microbiota composition moved towards the healthy like IBS microbiota after the treatment with a low FODMAP diet, indicating that gut microbiota diet interactions are of importance for the symptom response in these patients. There are also other type of treatments options modulating the diet that can actually improve symptoms. This is from a recently published trial from our group, where we not only use a low FODMAP diet, but also we have had a group with a diet which was generally low in carbohydrates. And as you can see here, over the 4-week intervention period, these two diets were better, superior to an optimized medical treatment paradigm, or the OMT group here, when it comes to reducing IBS-type symptoms. And you can see on the right hand side that the proportion of responders were clearly greater in the both dietary arms compared to the optimized medical treatment. And what was also nice to show was that this response seemed to be durable. We had almost the same proportion of responders at 6 months follow-up in both dietary treatment arms. So this is promising. So even though I showed you some treatment options that show some promise when it comes to improve symptoms by modulating the gut microbiome, we are still the superiority over placebo is relatively modest for many of these. So we certainly need to improve our treatment options by doing more research on the host physiology, the microbiome, and also what you can call the exposome, where diet and other environmental factors are included. And probably to do this, we need to understand more how these different factors integrate or interrelate with each other by doing not only cross-sectional but also longitudinal follow-up studies, trying to address how these different layers influence each other. And hopefully then we can develop new therapies going to targeting more distinct mechanisms, specific processes, rather than influencing the entire gut microbiota community. And this will then influence our ecosystem less and have also less negative ecosystem consequences if we target more distinct mechanisms rather than communities. So this is my final slide. I hope that I convinced you that there are clinical scenarios supporting the relevance of gut microbiome for GI symptom generation. There seems to be gut microbiota alterations in at least subset of IBS patients, and therapeutic interventions aiming at modulating the gut microenvironment in IBS are useful. I show some data on anti, pre, and probiotics, fecal microbial transplantations, and dietary interventions. And with this, I would like to thank you for your attention. Thank you.
Thank you very much, Magnus, also for a wonderful talk that also gives, I think, rise to a number of questions. There are already some questions in the question and answer sections, but if I may start to the discussion here. Gerard, you were showing that the early childhood experiences and also the use of antibiotics in children does play a role, number one, in the generation of or the evolution of the microbiome, and also we also know that this affects the incidence of IBS. So we obviously are dealing with these patients way later, but we have a lot of patients, and the question is, are we doing this too late? Do we have to have more strategies during early childhood? Should we also, Magnus, move probiotic treatment also more towards the very young population to avoid that the microbiome is changed for life, and that also to reduce basically the incidence of IBS? Is this something where we should focus on more?
Yeah, no, I think I would agree with that, Daniel. I mean, there's an important assembly trajectory of the gut microbiota, I suppose, over the first number of years until it stabilizes into an adult one, and that assembly trajectory kind of overlaps with key developmental aspects, both in the central nervous system and aspects of the gastrointestinal tract as well. So if we can identify specific windows during which we can intervene with specific designer probiotics, maybe to ameliorate the specific aspects of brain function and gut function that are regulated during those critical windows, that would be a good approach. But I think we have a bit of work to do yet to be able to do that with the precision needed, maybe.
So I guess going along those lines, number one, unfortunately, the trials that we see do not show huge effects over placebo. And you've also shown that the FMT data are a little bit all over the place. We have the excellent data from Norway, which are really, astounding. And I think we all were astounded when those came out. There's follow-up studies now going on. Also taking the approach from that group to other centers to try to replicate this internationally. Now, one of my questions is, when we use probiotics, and you also showed that then the most guidelines now, including, by the way, the German-speaking guidelines that you didn't mention, advocate for the use of some probiotics. Are we not taking them long enough? Do they only work while we take them? Can we do something to have something more of an engraftment of these probiotics that we give to our patients? What about those strategies? What do we tell our patients? How long should they take it? And how do we do this practically?
Yeah, I mean, there are few studies actually demonstrating how long we should take probiotics. I mean, there are some long-term studies that show a sustained effect when we take them for, let's say, 6 months. There are some trials that has continued for that long, but most studies are relatively short, up to 12 weeks, some of them shorter, and most of them actually show that the beneficial effect of the probiotic fades away when we stop taking them. So yes, there might be an idea to recommend the patients, once they have effect, to continue with the probiotics, but we don't have really good evidence from clinical trials how to do it. I mean, could we take some time off and then start again, etc.? These trials are not there, but in general, most studies support that you should continue to take them when you have started taking them, if you have a positive effect. And also to my patients, I say, if you don't have an effect, I recommend them actually to stop. So I don't continue forever. Most trials show an effect at least after 6 to 8 weeks. And if you don't see an effect there, from a logistical point of view, I tell them, well, probably that's not the drug for you.
Mm-hmm. Integrating a question from the audience here, by Alex Gonzalez, he's asking, if we use antibiotics first, and then a specific probiotic to improve the microbiota, possibly also to improve engraftment. Is this something that you would recommend or not?
I would not recommend it, because I don't think we have any clinical data supporting that this actually helps, at least not from the human side. I don't know whether there are some animal studies supporting it. Maybe Gerard can help you there, but from clinical trial point of view, I don't think we have any data supporting this. And actually, we don't, I mean, since many of the effects of the probiotics not necessarily relates to engraftment, if you put it like that. I mean, we can also give postbiotics, and there are some studies, and we don't even need the live microorganisms to improve symptoms. So I don't see a reason clinically to do this at this stage, even though the trials need to be done, of course.
Enrique, do you have some questions?
Yes. I was going to ask actually something similar to Magnus, because I think there is no data to combine, I mean, all those strategies. For example, providing prebiotics, probiotics after a shot of antibiotics, and maybe combining with a diet, no? Mm-hmm. I mean, I think, and that will be a huge effort to do that kind of clinical trial. I don't think that is actually as easy to do. So what are your thoughts about it?
I personally, I mean, as I said, no clinical studies supporting this. I mean, if combining all of these together, and also maybe limited rationale to combine all of them. But I mean, there are some studies combining a pre and probiotics, when you call it symbiotics. There are some limited evidence suggesting that might be a beneficial for patients. In my clinical practice, I try to rather, if I combine something, I combine with drugs that target some other mechanisms. For instance, a drug that targets hypersensitivity, for instance, combining with something modulating the gut microbiota. I know that there are no studies supporting that, but I think that makes more sense to target potentially different mechanisms of action when it comes to treating IBS in general, rather than trying to combining things that I wouldn't say affect the same thing, but affect a similar niche, if you put it like that. But beyond clinical studies.
I'm not sure if there's many preclinical studies specifically in the context of IBS. If I'm remembering correctly, there was a study from Aaron Alalaf a number of years ago where they showed probiotics actually delayed the recovery of the microbiota post antibiotic treatment. So it's not a given that it would be necessarily completely beneficial all the time.
Yeah, and this study was highly debated, obviously, right?
Yes, it was controversial for sure.
Put a lot of controversy into the discussion. But yes, I think we all agree we need more data, and I think the combination of things. And you mentioned foods, right? And there's also some questions in the audience about foods. Magnus, obviously we feed our microbiome. Also, Gerald was referring to this. He talked about the tryptophan, the tryptamine, and all these food products or microbial products that are generated from food that obviously also have an effect on the microbiome. So what are we doing there? I mean, we all agree that low FODMAP works quite well. We also have seen it has some effects on the microbiome, which we possibly don't like over time. We also have, you've shown, Magnus, that there's strategies to reduce that microbial change by adding prebiotics possibly to that. Now, there's also a question from the audience going into this food direction from Miguel. He says, low FODMAP Mediterranean or the NICE diet, which one do you prescribe more often in the clinic for your IBS patients?
I mean, normally when we see a patient first time, we try to be less restrictive than the low FODMAP diet. I mean, most of the time we try to start with a more general dietary advice of trying to have them eat a healthy diet first, and that's appealing then with the Mediterranean diet, even though there are not so many studies supporting its efficacy in IBS yet, but there are some studies supporting this more healthy diet. So I think I normally try to start with that before I go into more restrictive diets, which, as you alluded to, might have negative effects in the long run. And what is important when we do these restrictive diets is that they should not continue on a very restrictive diet for a long time. They should reintroduce after a restriction phase. They should reintroduce foods which are rich in FODMAPs again and see what they can tolerate, so they can have a more personalized diet in the long run. But I start with less restrictive diet for patients first, and if they work, I stop there.
I guess there is an interesting recent study from Heidi Stoudasher in the context of the Mediterranean diet, which at first glance would be kind of counterintuitive that a diet highish in FODMAPs and fiber might be beneficial, but she did seem to show it was useful, particularly in those with psychiatric comorbidity, which I thought was interesting.
Yeah, agree. So and that's actually more appealing to follow a Mediterranean diet for other reasons than follow a low FODMAP diet, because it's of course a much more healthy diet. And I guess coming back to what we discussed before, intervening early, I think it's probably more likely at the community level that we will try to advocate a healthy diet to our kids than we will feed all our kids with probiotic products in the future. I think hopefully that is a better way forward. I don't know what you think, Gerard, about that when intervening early.
For sure, no, I agree that that's important. It's also a lifelong habit, I guess. So if you start early,
And Magnus, I was more referring to the time of breastfeeding, for example, right?
Yes.
There is this time, and actually, the pediatrics recommend to give certain probiotics to children now, and a lot of people do it. However, I'm not sure how good the evidence is, to support whether that does anything. But yeah, absolutely with you. The healthy foods should be advocated for our youngsters for sure, although they often don't agree to that.
Problematic.
There's a specific question about Akkermansia muciniphila or Blautia from Miguel, whether there's a promising future with these more modern or more recent probiotics.
Maybe Magnus can come in as well, but I mean, I think I like the idea that there's maybe a stronger rationale. Maybe the current probiotics are generalist approaches, and the newer generation ones might have a stronger rationale behind them, might be targeting specific mechanisms. I think because they're kind of categorized in many jurisdictions, and America, for example, is investigation on new drugs, there might be some challenges getting them approved to treat a specific medical condition. So that's the challenges I would see, although I do agree they're promising options.
Yeah. Yeah, I agree. I mean, as we've seen from my slides, there are definitely need of better probiotic and other biotic treatments for patients with IBS. And these are, as you alluded to, there are promising treatment options, but still no large-scale clinical trials that can support the use in clinical practice.
Mm-hmm. As a closing question, we also have a question from Adam Farmer that thanks you both for your excellent talks, first of all. And he's saying that most trials of therapeutics in IBS have an NNT or number needed to treat of around 15. And do we need to move beyond the pure symptom or temporal definition of IBS? And we need to look more at endophenotyping. So basically, do we have to target our patient population or to understand them better in order to improve our treatment outcomes? Also, possibly in terms of on which patient to use which probiotic.
Ideally, yes. This is what we're trying to achieve, even though it's been difficult to show that. I mean, that we have some kind of biomarkers or endophenotypes that actually can predict treatment response. I think this is something that we would like to have, but we are not there yet. So I agree with Adam that this is something that we hope for in the future, and hopefully can lead to better treatment outcomes in IBS.
Yeah, I think the paper I mentioned from Paul and Toole and colleagues was an interesting option, maybe where they identified not just strains that were enriched and depleted, but also if you read into that paper, they were able to show specific strains that were responsive to specific diets or rifaximin, for example. So the idea that the microbiota might be a biomarker reservoir that could be used in companion with specific treatments is appealing, even though, as Magnus says, we're not there yet.
Yeah. Well, we could possibly continue this conversation for much longer, but we've elapsed our time a little bit over it, and I need to go back to bed now because it's 5 in the morning. But anyhow, no, it was wonderful to have your talks, Gerard and Magnus, also Enrique. This has been really fun organizing this together with you. I'd also like to thank our partner Ferring for supporting this global webinar series, and Enrique, we are getting back together to do another webinar together with you and colleagues on the 27th of November at the same time, so 8 p.m. for you in Mexico, and it's going to be again 4 o'clock in the morning for us in Europe, and we will focus on in that webinar more specifically on Clostridium difficile infection management, FMT in those regards. So Enrique, you want to say a few words as well?
Yes, I'm joined to the congratulations to Magnus and Gerard talks, and have been very wonderful. And thank you so much for this joint webinar. So we're looking forward to for November the 27th. So we appreciate, and I want to enhance that you are doing a big effort to be here. And very proudly, we will wait for you next month. Next November.
Thank you all very much, and have a good evening and a good morning.
Thank you.
Thanks, everyone. Bye.
Bye.
Bye.